Okay, let's get started. Before the training started, we want to actually give you a few announcements. Please mute your microphone. And so if you can, please change your name, show your name, institution, and also country on Zoom. And so we can see where are you from. I would see that we have probably multiple countries is coming to this SBRT and SRS training. And if you have questions, please type in the chat. We're going to monitor and answer your question during this training session. And please also register through the Google Sheet. I just put in the Google chat, in the Zoom chat. The reason why I want to see who's coming to this training session, if you complete 5 of the 6 training sessions, you will receive a certificate from us. If you miss the first training session, we have recorded. So I believe Geneva already sent you the link, so you can watch the video. And also have another request: please complete the surveys before you join this training. I want to see the baseline experience on SBRT and SRS. The reason why we do this training is from actually a few years ago during the pandemic, we conducted a few training focused on IMRT, and it turned out very effective to support developing countries on this new technology. As time goes by, I think most of the countries we work together already have IMRT and at least starting to think about SBRT and SRS in their department. That's the reason why we decided to organize this online training. And if you are the first time to come to this training, this is our agenda. And we already had one training session focused on brain about 2 weeks ago, and Dr. Siddiqui from Baylor College of Medicine and myself. So we already gave one training session. Today, we are going to have another training session focused on prostate, bone mass, and we have Dr. Guy from Washington University in St. Louis, and have known him for many years. Very passionate about MSc training and support the developing countries. And he has over 20 years experience in radiation therapy. Currently, he is the chief of GU at the Washington University in St. Louis, and he's also medical director at Cytomic Cancer Center, South County. The physical speaker is Dr. Hao. He's also from Washington University in St. Louis. He's one of the best physicists I have seen in the past, and he experienced a very strong clinical experience, almost everything. He covered adaptive radiotherapy, MR guided, SBRT, he's doing SBRT. He's the chief of proton therapy at the Washington University, St. Louis. And thank you very much for joining us in this training session. So, Dr. Guy.
Thank you very much. Can you see me okay?
I can see you, yes.
Yes.
Okay, so, hello, I see some familiar faces, from Mongolia, from Uganda. Nawel, we had a recent session, and, welcome everybody. We're just going to be, exploring this, new technology, indications for technology in prostate and metastasis management. And feel free to interrupt. And, let me know if you have any questions. I want this to be an interactive session. Okay, so let me share my screen. Okay, can you see my screen?
Yes.
Okay, well, let's get started. My name is Hiram Guy. In Spanish, it's Iram. and we're going to be talking about prostate and bone metastasis management. So these are real cases. This is a patient who's 74 years old with high-risk prostate cancer, had initially Gleason score 7, PSA 4.3, had a surgery. At surgery, he had Gleason 4+3, had a focal positive margin at the left apex, and his PSA had been rising slowly. So in July, it had reached 3. So it really never nadir. They just kept going up. And this is a case of oligometastases. So with the help of the PSMA PET, this patient, in the blue arrow, we can see here, let me see if I can show my pointer, laser pointer, here we go. So there's a little retrocrural lymph node that's lighting up. And, I want to highlight that, the PSMA PET, when we detect this lymph node metastasis, usually they're very small. It would be very hard to tell on a normal CT whether that's involved. I mean, if I had seen this CT or the radiologist, they wouldn't have thought this is suspicious. But when we look at it in the PSMA PET, we do see a lymph node there. The patient also had another lymph node in a very unique area here. So I'm pointing that there. So that's our second oligometastases. Then there's a left periortic lymph node. This one is more subtle, how it lights up, but here I'm pointing that lymph node. So we have now 3 targets. And then this one, eventually we decided this was a left supraclavicular lymph node. There was some debate whether this was a ganglion, but here you can see the supraclavicular lymph node. Usually in prostate cancer, when you see these nodes, it's going to be in the left supraclavicular area. So to me, it made sense that we had a lymph node in this area. These are unusual, but over the years, I've seen a number of patients who have left supraclavicular lymph nodes with prostate cancer. So this patient participated in a trial. It's opened worldwide. They want to enroll 450 patients. We were the first ones who opened the trial in the United States. And we are top enrollers in this trial, but we've just put like 2 patients, maybe a 3rd patient. So a lot of patients, for some reason have failed the screening. So far, we've enrolled 2, and we're about to enroll a 3rd patient. So it's a 2-to-1 randomization. So all the patients are going to get SBRT to the oligometastases. And then 2 out of 3 patients will get 4 cycles of lutetium PSMA. And 1 out of 3 patients will have observation. The idea is to see if with a radiopharmaceutical, we can avoid hormonal therapy on patients. So can the lutetium take care of micrometastatic disease that we cannot see? So we'll see. But this patient participated in this trial. What dose? There's multiple ways of treating these oligometastases. If you look at different protocols, there's multiple acceptable ways, but I'm just going to show you, one of my favorite dose schemes. And for comparison, I want to show 5 gray times 5. So this one here, the alpha beta ratio for prostate cancer, usually we think it's around 1.5. So if we do 5 gray times 5 fractions, the equivalent dose is like 46 gray. So this is a good dose for maybe elective pelvic nodal disease. And we have a protocol that actually uses this. I think in some hypofractionated instances, people have used it in GYN. It also has a track record for elective areas in rectal cancer. Then just to compare that, 6 gray times 5, the alpha beta ratio is 1.5 for prostate cancer. So it would be the equivalent of giving like 64 gray. For normal tissues, the alpha beta ratio of 3 would be an equivalent dose of 54 gray. So this might be a good dose when you might be close to small bowel, like you want to give a little bit higher than 5 gray times 5, but you're close to bowel or some critical structure. It's still higher, but it's still not as high as if you were giving a definitive dose to the prostate. And then usually, my go-to dose for prescribing this oligometastasis is 7 gray times 5. So for the prostate cancer with an alpha beta ratio of 1.5, the equivalent dose in 2 gray would be like 85 gray. So this is kind of like, when we do SBRT to the prostate, we might do 7.25 times 5 or something like that. So this is a more powerful dose to the prostate cancer. However, to the normal tissues, it's like giving 70 gray. So you just have to be careful if you're close to bowel. Sometimes we might use adaptive radiotherapy to monitor that or cut our margins, etc. But, these are different schemes. There's schemes in 3 fractions that I've seen in protocols in 2 fractions, etc. But, I usually calculate these to get a sense of, what does the normal tissue see with an alpha beta ratio of 3? What does the prostate cancer see with an alpha beta ratio of 1.5? I use an alpha beta ratio of 2 for like the spinal cord. So, for the spinal cord, 5 gray times 5 would be, 43 gray. For 6 gray times 5, it's too high. It would be like 60 gray. And for the spinal cord, in 7 gray times 5, it's 78 gray. So you have to be very careful to pull those higher doses away from the spinal cord. Okay. So the upper abdomen targets, in this case, you can see where our node is, and you can see the GTV and the PTV. And, one thing that's important when you have these oligometastatic cases, make sure you're fusing the right anatomy corresponding to that GTV. So in this case, we fused the spine in this area, which is the correct way, but you can see that down inferiorly, it's not well aligned, just because the priority was to align the anatomy where we have this gross tumor volume, where we have this PTV, but the result is lower down. When you see the fusion, it's not aligned, and that's okay. When you look at your fusion, here our dosimetrist gave us some information that, this is a registration by the spine up here. These are the retrocrural lymph nodes, as I had mentioned. Here's our targets, on the axial view. Here's like zooming it in. Here's the other target. Here we see it drawn here with the PTV and zooming it in. And here's our VMAT plan. So these 2 lymph nodes were close to each other. So, we have our dose distribution. We can see that we're rapidly, our prescription was 3,500 centigrade, which is the blue. But very quickly, we drop it to 2,500 centigrade. So, very conformal. Here we're pretty safe with the anatomy around it. Here, the main thing is the, vessels, but, the aorta can tolerate a lot of those. Our lower abdomen target. So now here we see that we have a target lower down. So now the fusion is aligned here in this area very well. And now the upper spine is not, different from the other target that we had before that was here. So this other target is lower down, so we're very well aligned here. And here our dosimetrist put us a note for the, it's fused by this sacrum lower spine. And here's where the lymph node was. Here's our GTV, our PTV. We really don't have a lot of bowel around. Here's zooming it in. Here's our plan, very conformal, dropping the dose very quickly. Finally, our next supraclavicular target up here. Here you can see it in the axial view. Zooming it in. Here, it's doing an arc from that side. And then, one question I have.
Dr. Guy,
yeah.
Let's some question in the chat.
Yeah. Okay. Let me.
So basically, what is the cutoff PSMR SUV?
What's the cutoff SUV? I don't think the radiologists necessarily use a specific cutoff. I may be wrong. Usually, they'll that part is that's probably better a question for a radiologist. I personally don't use any SUV cutoff. I rely on the read from the radiologist. So they usually tell me in this axial slice, they'll number it, let's say on axial slice 135, there's a left pelvic lymph node or sacral lymph node or whatever it is. And that's usually how we go by it. So I rely on their expertise. There's areas that are a little bit more confusing that you can get some false positives. Sometimes the ribs can have some false positives. And when in doubt, we discuss it with our radiologists. But I don't think it's like head and neck necessarily where they have a specific SUV cutoff.
Yeah. Do you think that SBRT can target small lymph nodes precisely and dosimetrically? How about PTV margin?
Yeah. So PTV margins, I think so. If you do a cone beam CT, you can very precisely treat these nodes. I'll use from 3 millimeters to 5 millimeters margins. So if it's an area that there's not a lot around that I'm worried about, I'll probably use a 5 millimeter margin. If it's a small target that I'm not worried about the bowel, for example, I might just expand it by 3 millimeters or do it asymmetrically. So in the direction where I'm getting closer to the bowel, I may do 3 millimeters and then maybe posteriorly or to the side do 5 millimeters. So I work with the dosimetrists to try to help them achieve the goals. But I would say most of the times between 3 and 5 millimeter margins is what I use.
Another question is what type of radiological model being used for EQD calculation? Is LQ or LQL?
What type of calculation?
Radiobiological model. I probably think that LQ, right?
Yeah, that's a linear quadratic model.
Yeah.
This
Okay.
website, you can find it online. It's you can put EQD2. It's the LQ model. Nothing too fancy. You know, I'm sure there's fancier equations, but I just use the linear quadratic model. And the EQD2, in case you're not familiar with it, is the equivalent dose in 2 gray. And you know, you can pull up that website. It's you know, when I want to do a quick calculation, I just look for this website and plug the numbers in.
Okay, I saw our Dr. Abadana is here from Baylor. He can help answer the question in the chat. In this way, I will not interrupt your presentation. How about that?
Oh no,
Okay.
that's
Keep
fine.
going. Yes.
Let me. Do you want me to
Yeah.
just interrupt me every now and then with questions? So I have a question for the audience. Who wants to volunteer?
What's your question? Is on the slides?
Okay, so the question I have there on the screen: would you consider treating the regional lymphatics instead of just the SBRT to these nodes? Would you treat a larger area too?
I guess this question is for the radiation oncologist.
For
Okay.
radiation oncologist.
I saw the no at this stage. Okay, several answers.
Solomon, what do you
Okay.
think?
Solomon probably does not have audio. Let's see. Yeah, but there are several answers that no at this stage. in the
They
chat.
wouldn't. They would say no at this stage. Let me
Yes.
let me see if I can pull the chat, because for whatever reason, okay, here we go. Sorry. So this is not at this stage. You could, I don't think there's a straight answer. I will tell you my experience. So in the pelvic area, if I didn't treat the pelvic area before, I usually treat the pelvic area and do SBRT to the lymph nodes. Usually, I might do like a traditional 45 gray and 55 gray at 220. If the patient never had pelvic radiation, like a post-op case or something like that. In some cases, if the patient had previous radiation therapy to the pelvis, I'll just SBRT the pelvic lymph nodes. Now, what I have seen with the periaortic recurrences, so if you have a lymph node higher up in the periaortic area, like in this case, I've sometimes treated just the lymph nodes, but I would say half of the time it'll fail higher up. So that's made me change my practice for the periaortic lymph nodes in particular to treat a regional area. So, these are palliative patients, but, an aggressive palliation, right? Like oligometastatic. So, I might give 5 gray times 5 to a larger volume in the periaortic area, and then boost the lymph nodes to 7 gray times 5. And I think there's some publications, some retrospective publications showing that too, that sometimes if you just treat the node, you might fail, in other nodes, further down the line. So I just wanted to share, my preliminary experience. Usually I haven't had failures down in the pelvis. It's usually in the periaortic area where I'll see a lymph node superior to where I did the SBRT that then fails. Okay, so case number 2. So this is a 59-year-old male. It had a biochemically persistent prostate adenocarcinoma, had an nadir of 1.6. Then PSA kept going up to 2.64 in May of this year. He was unfavorable intermediate risk on presentation with an initial PSA of 7.4, Gleason 6, 8 out of 12 cores involved. He had surgery in September of 2022 and had 25% of the gland involved with prostate cancer. So a PSMA PET scan from July of last year showed evidence of avidity within the prostate bed, but not node or distant metastatic involvement. So here's that area in the prostate bed where I'm pointing that had a little avidity. So would you treat the pelvis? Would you give hormonal therapy, and for how long? Anybody who wants to put that in the chat? So I'm gonna move ahead. So this is the NCCN guidelines, in terms of treatments. You could do external radiation. You could do, plus minus hormonal therapy, right? If the patient had a low life expectancy, you could do observation. But this graph is from the SPORT trial. So in terms of the benefit of pelvic radiation, prostate bed radiation, pelvic lymph node radiation, we see that in terms of PSA control, the best results is treating the pelvis, treating the prostate bed, and short-term hormonal therapy. So that's the green. So if you give everything, you get the best PSA control. If you do the prostate bed only and the hormonal therapy, you get the blue line, so second best. And the worst in terms of PSA control is prostate bed radiation alone. Now, we haven't seen an impact in terms of overall survival here. So overall survival is the same. But if you want to make an argument of what gives you better PSA control, treating the prostate bed, treating the pelvis, a short course of hormonal therapy would be the best. There's even more recent data showing that 2 years of hormonal therapy will lower your risk of distant metastases. It's something we don't do routinely here because it takes quite a number of patients to benefit a few, but it's something else you can consider. So here's our prescription. We have 4,500 to the pelvis, 6,660 to the prostate bed, and then I gave a boost to that PET avid area to 7,200. And this is our prescription scheme. All fractions are at 180 centigrade per fraction. Here's our pelvic target, receiving 4,500 centigrade. And there's plenty of atlases showing you how to draw this in terms of patients who had a previous prostatectomy. Then this is our prostate bed 6660 target. And then I drew that GTV for the PET scan and gave it a generous margin. And that's the area that I'm giving 7,200 centigrade. And you can see the VMAT plan. You can see the different isodoses, how they, as we get farther away, we drop it quickly. We're trying to get it out of the femoral heads, the dose. Okay. And exactly. So we have a comment in the chat about radicals. Correct. We haven't jumped into the 2-year bandwagon, but yeah, in terms of distant metastases, yeah, we 2 years seem to be better than 6 months. Okay, our third patient. So this is a 72-year-old gentleman with, hold on, there's somebody from the chat. You know, I usually treat the pelvis in these post-op cases. I didn't used to, but I just want to reduce the chance of having a pelvic failure. I think you could decide on a case-to-case basis. There's an energy trial looking at hypofractionation. I know some people in the community do hypofractionated regimens for a case like number 2. So I think it's okay. You know, we tend to be more in the 1.8 gray per fraction for the post-op cases, but some patients do, you know, I've seen radiation oncologists do hypofractionated regimens, and I think that's acceptable. Case number 3 is a 72-year-old gentleman with prostate cancer and had bladder and seminal vesicle invasion. Initial PSA 394. So to me, a patient with such a high PSA, you know, is metastatic unless proven otherwise. But all the scans seem to indicate that this gentleman did not have any metastatic disease. So, you know, reminds me of my visit to Uganda. Like they had a case like this, like a patient with, you know, a PSA of, I don't know if it was 200 or 100, but they scanned the patient. They have CT for staging, and, you know, they couldn't find any metastases. And the question is, what do you do? I did all the types of scans for this patient, but we couldn't find metastases. So we're giving the patient the benefit of the doubt and treating him definitively. And, you know, if I looked at this, at first glance, I would think, oh, this is a PET scan showing the contrast in the bladder. But that's not the bladder. That's actually the patient's prostate that is completely infiltrated with cancer. So all this is just cancer. Here's higher up. This is the actual bladder higher up, and then maybe some seminal vesicle area there. So they found some right perivesical lymph node tracer, some bilateral distal external iliac lymph nodes. And here they give us some measurements. They mentioned the SUV. And, you know, here's how the image looks in CT. You can see here, like the cancer is just like abutting here the rectum or infiltrating the rectal wall. Here's a coronal view of the MRI. So here's the prostate. Here's the bladder. So T stage, you know, it's a T4. Like this is the worst case scenario for, we don't see this often in the United States, but this patient has definitely a T4 invading the rectum, bladder, and the risk category, you know, it's going to be very high. You know, a T4 makes you very high to begin with. We have, you know, very extensive disease. You know, how would we treat? You know, I think for a very high risk patient like this patient didn't get abiraterone, but you know, probably it's somebody who we would consider abiraterone, hormonal therapy, like 2 years of hormonal therapy at least, and radiation therapy. That's usually, you know, how we would treat a patient this aggressive. Treatment volumes and dose. Just think about that in a second. If anybody wants to volunteer, or you know, what would you treat? What dose would you give? Feel free to put anything in the chat. So So if we see, we have different, dose and fractionation schemes, I would treat this patient definitively. So I see somebody saying prostate, seminal vesicles, the part of the bladder involved, pelvic lymph nodes. I agree with Jalil. That's what I would do. Try to give it at least 2 months of hormonal therapy to try to shrink it. I think the target is so big, I would be afraid of doing SBRT. And it's also invading into the rectum. I think the chance of a rectal injury would be higher. Bladder injury would be higher if we do SBRT. So I went very conservative, old school. And, in this case, the total dose we did was like 44 fractions at 1.8. So very traditional, old school, and then 4,500 centigrade to the pelvic lymph nodes. So here's our prescription. Actually, 50-40. 50-40 to the pelvic lymph nodes just because the patient had multiple lymph nodes, so we were more aggressive with the pelvis. Usually I'd give 4,500, but I went to 50-40. Then 61-20 to some lymph nodes that needed to be boosted, that were avid on the PET scan, and then 79-20 at 180 for the primary tumor. For the Roche formula, we here at WashU, if it's high risk, we treat the pelvis. We usually don't go necessarily by the Roche formula. That's a potential approach, but traditionally, historically, right or wrong, if it's somebody high risk or higher, we're going to be treating the pelvis, and we've been doing this for many years. But somebody with a T4 with such a high PSA, I would definitely treat the pelvis. So here's our not 4,500, but 50-40 centigrade target. You can see where we're treating the pelvis. These are some of the nodal areas that we're boosting to 61-20. And then we see the 79-20 centigrade to this area. Okay. And here's our plan. And now we're going to go fast and cover some SBRT cases, okay? So this is a 60-year-old male, favorable intermediate risk prostate adenocarcinoma, had an MRI of the prostate with a lesion in the right anterior fibromuscular stroma, underwent a prostate biopsy, had one positive core with Gleason 7. Here's the PSA history. We obtained the cipher. So this is genetic testing, and the tumor was low risk according to the cipher. Here's our prostate, and here's Barrigel. I want to show you how the different spacers look. So this is Barrigel, it's hyaluronic acid. This is how it looks on MRI. In MRI, it looks beautiful, but in CT, it's hard to see. So for clinics that don't have the benefit of the MRI, it might be a little bit tricky to see on the cone beam CT, but here it is. It's a little bit darker on the CT. How would you treat? Very straightforward. This is a patient that we would do radiation therapy alone, SBRT to the prostate, maybe proximal seminal vesicles is enough. So here's our prostate. Here you can see the proximal seminal vesicles that we treated. Here we gave 5 millimeter margins, and then posteriorly, I think we did a 3 millimeter margin or maybe 5. sometimes posteriorly we just do 3 millimeters and the rest 5 millimeters. Here's where we have our fractionation scheme, 7.25 times 5. Here's our prescription. Here's our VMAT plan. In magenta here is the Barrigel. And here's different views of the plan. Okay, this one is another patient, PSA 576, Gleason 3 + 4 = 7, 3 + 3 Gleason disease with 7 out of 19 cores involved. Now, here we use spacer view. So this is another another spacing agent. So you see that in MRI, you don't see it as clearly as the Barrigel. But when you look at the CT, you can see it very clearly. So, you know, a lot of locations that don't have necessarily an MRI for simulation, and, you know, this can be seen in the cone beam CT, in your CT, very clearly. So this is a spacer view case. Again, the same thing, 7.25 gray times 5. Here's another one. This is a 74-year-old male, Gleason 8, PSA 14.78. This is a case where we use the BioProtect balloon. The balloon is here. It's really hard to see on the CAT scan, but you can see it here on the MRI. You can see it here in the sagittal view. So this is another spacing product. It can achieve a lot of spacing, more than the others, because it can inflate quite a bit, but it requires an incision. It's a little bit more involved of a procedure. Here's, in this case, this patient is receiving 4,500 centigrade to the prostate, 6,250 to the seminal vesicles, and 7,000 to the prostate. And finally, did I say this right? Yeah. So this wasn't SBRT, but, you know, hypofractionated radiation. So 250 centigrade per fraction. Okay, this is the last one. And I'm just going to finish with this one. This is a 71-year-old with unfavorable intermediate risk prostate cancer, 13 of 14 cores positive, 4 + 3 = 7, initial PSA 8.8. Now, here, this is a patient that's been treated in a adaptive protocol at WashU. So the MRI showed 3 lesions. And in this protocol we boost the lesions to 10 gray times 5. I'm just going to skip over the algorithm here. Here's the schema of the protocol. So the pelvic lymph nodes get 25 gray times 5 in this protocol. The prostate gets 36.25 times 5. The prostate itself goes without an expansion to 40 gray times 5. And then the MRI guided, the MRI intraprostatic lesions get 50 gray. And here in green is one of those lesions that we're boosting. Here in red is another lesion. Here's our, prostate volume or pelvic lymph node volume. You can see other targets here in the sagittal view. In the coronal view, you can see all 3 lesions, green, red, and yellow. And here's the prescription. Each lesion is getting 10 gray times 5. This is an adaptive protocol. The PTV to the prostate, 800 centigrade times 5. Prostate plus seminal vesicle, 7.25 gray times 5. And the pelvic lymph nodes area, 500 centigrade or 5 gray times 5. Okay, that's it. Happy to consider any questions, or if you want to go ahead with, I don't want to delay.
Thank you very much,
Dale's
Dr.
presentation.
I think we have another presentation from Dr. Hao, also from WashU. He's going to talk about the physics aspect about prostate. using SBRT. Dr. Hao, please.
Let me share my screen.
If you have any question, feel free to type in the chat.
Can you see my screen?
Yes.
Thank you. Thank you for the nice introduction, Dr. Song. Hello, everyone. My name is Yao Hao. I'm a medical physicist, work with Dr. Guy in Washington University School of Medicine, Department of Radiation Oncology. Today, I'm gonna just focus on the prostate SBRT, like how we do things here. Let me see if I can get my laser pointer. Just a rough outline. I'm gonna go over some introduction slides, then look at the simulation and how we do the treatment planning, how we evaluate the plan, and intrafraction imaging, as well as the case Dr. Guy mentioned that we also do ESOS online adaptation. I could go over that briefly. So SBRT, stereotactic body radiation therapy. So typically we use a few fraction for SBRT, typically for prostate, more like a 5 fraction, pretty standard. We deliver high dose. A lot of time deliver like a GU005, deliver like a 3625 in 5 fraction. So the BED, as Dr. Guy showed, the biology effective dose pretty much for those SBRT cases versus 3D, they are more than 100 gray, and also require very high level confidence in the treatment delivery processing, and also including increased requirement in imaging, simulation, also treatment planning, and also the technique for delivery and intrafraction imaging as well. Here's just a nice table summarized by APM Task Group 101, comparing between conventional 3D conformal therapy, MRT versus SBRT. That you can see their dose scheme is very different, fractionation are different, target definition. Also, specifically for SBRT, a lot of time your GTV more like a CTV. The margin, it's a MRT 3D, a lot of time you're talking about the centimeter-ish margin, and SBRT more like talking about the millimeter. Also the image modality, a lot of time for SBRT, you may involve more than CT. You may have MR, you may have PET-CT, and others. Of course, there are a lot of other trainings requirement for SBRT more than traditional 3D or MRT, and so on. So kind of general requirement for SBRT immobilization is a very big thing. So in order to achieve a high dose delivered to very limited volume compared to a 3D or MRT precisely, you need a much better immobilization device. Also, you need an accurate position, repositioning imaging system. And also, a lot of time, the way how you deliver your beam for 3D MRT, you may have few fields or few arc lengths, total arc lengths, but SBRT, you probably have a couple arcs or more fields, sometimes more than 10 fields if you don't do arc therapy. Also, they have rigorous accounting for the motion, organ motions. For prostate SBRT, probably motion, we are really talking about the rectum or bowel motion. For lung, others, motion management become more and more important. Also, stereotactic registration of a tumor target at a normal tissue, so the treatment delivery machine is very important. we are really talking about sub-millimeter accuracy in SBRT. So modality-wise, pretty much those are like a common modality you can see for the standard SBRT kind of prostate treatment. There's like a C-shaped kind of a LINAC, or so like a saber knife, and also some of them treat by proton. Also, some of them now we offer those online adaptive ESOs can also do the job for prostate SBRT. Of course, I didn't put MR LINAC here. They also can do the same thing. Typically, you will see there fiducial markers with physicians put into patient prostate. They could be some like a gold seeds or visual coils. Here's just a kind of comparison. You can see the gold seeds and visual coils. Visual coils tend to create less artifacts. In our clinic, we use the visual coils pretty common. The general dimension we use is 0.35 millimeter in diameter and about a centimeter-ish in length. Usually we put physician put 3 or 4. On the bottom, you can see the ultrasound imaging. So usually in our practice, ultrasound imaging is pretty common too when we place physician place those seeds in the prostate. Yeah, Dr. Guy showed a very nice imaging before in his slides, the Barrigel. So Barrigel, just quickly look at the Barrigel shape itself. It's kind of balloon, and they insert just between prostate and rectum, and later inject the saline solutions into the balloon. It's roughly like here said, it's about 17 cc in volume, provide about 2 centimeter kind of separation. The total length is about 3-4 centimeter. And it's a kind of biodegradable with time. So it's good for the whole course of the treatment. On the bottom, just kind of showing the imaging. Look at the ultrasound, the CT, and the MR. Yeah, typically those procedures done using the ultrasound guiding, kind of insert the balloon. Dr. Guy also mentioned another one, which is a spacer view. Yes. Sorry. Is there a question?
Go ahead. It's background noise.
Oh, okay. Spacer view. Spacer view typically, typically they have the iodine in the solution that you can see from CT. On the co-beam CT here on the left side, this is by our vice chair, Dr. Michalski, provided 2020. You can see it's very good on the MR imaging. Typically, we use the T2 MR. On the CT, it's pretty obviously, and also even on the co-beam CT, you can see the spacer view. Yeah, this one is different compared to the Barrigel. It's not a balloon, actually. It's a kind of solution. Two different solutions mixed up, then inject between the rectum and the prostate. It's very helpful for the rectum sparing. In the same time, also help with the contouring workflow. Simulation wise, generally in our clinic we have a CT simulation. We also do MR simulation. Generally, it's a T2 weighted scan. Sometimes we do have a PET CT simulation, not in our department, but from radiology. Some of the patient, like Dr. Guy mentioned, some of the patient we made dose escalate to 40, even 50 gray. I can show by then, like ESOs adaptive, we do treat those cases. For simulation wise, we are in the transition from alpha cradle to backlog cushions, because alpha cradle generally you have two kind of solution mixed together, then they form the shape for the patient. It's kind of messy a lot of time, and now we are kind of close to fully transit to backlog back, which is more like a it's like you take the air out and patient lay on, then shape the cushions based on patient body. For prostate, we do supine position Typically, the patient put their arm on the chest. It's more comfortable, and also it's kind of away from the beam entrance. We bend patient feet. We ask a patient keep a full bladder and empty their rectum. For CT scan itself, we use the Siemens CT scanner. The slice thickness roughly about 1.5 millimeter thickness. For the field of view, it really depends. The 650 should be sufficient enough to cover the CT couch table laterally. We use a carefully dose to do dynamic dose regulation for the CT scan. Contouring wise, organs such as the rectum, bladder, urethral, because you have fully helped to define the urethral, femoral heads, penile bowel sometime. Typically, physician, Dr. Guy will contour the urethral and also the penile and also bowel. Of course, the target as well. Also, there's an OAR generation urethral plus 2 millimeter, just try to give you a buffer for urethral. Target-wise, generally the CTV is made based on the prostate, about roughly about a centimeter, depends the case, involves the proximal semivascular. This is used by the fusion of MR and the CT help to see where those organ set is. PTV generally it's based on the CTV plus 5 millimeter on all direction except for posterior. So typically that direction the 3 millimeter. Also there's a spacer OR help with the further spare rectum. So treatment planning for generally SBRT, we kind of follow the G005 prescription for most of the cases of our SBRT. It's a 5 fraction, 7.2 gray per fraction. We treat the patient every other day. The isocenter, usually you put in the center of the target, pretty much the prostate. And the dose grade, we use a 1.5 millimeter. And the calculation algorithm use a AAA. It depends. If we use the ESO-based online adaptive treatment, or even not online adaptive, for ESOs, we use the Accura's. That's the default calculation algorithm. Energy, it's a 10 FFF. Typically, this can deliver much faster. So you can do 2400 MU per minute. It's much faster delivery. For the ESOs-based, because it's a 6 FFF on ESOs, you're not able to achieve 2400. It's about 800 MU per minute. For the arc, generally, 2 arcs should be sufficient using VMAT technology. And we don't really intend to treat through the rectum. So there's a 30-degree on the bottom. You can see we don't treat through there. So pretty much 2 arc 720 degrees, subtract 60, you're roughly about a 660 full arc length. Clockwise from 195 to 165 with collimation rotation. Then you do reverse your arc and with also rotate the collimation to 345. For the planning wise, hotspot prostate, not like a traditional, like a lung, you kind of try to hit hard, very hot in the ITV, but prostate generally, based on the G005 protocol, they kind of recommended the point dose 0.03 cc, roughly less than 107% so it's acceptable for 120%. Coverage wise, pretty much 99% of volume receive 95% of the dose, 98 receive the full dose. Optimization, we typically start from rapid plan templates, which is very convenient because it's pretty much for prostate and the partial semivascular involvement. It's the relative geometry is pretty standard. We can use the rapid templates. Of course, if patient have like say hippocampal replacement, kind of femoral replacement, then you may not able to. You may need to modify your starting and ending angle a little bit. It depends case by case, but most of the time it's very standard arc length and also again, the collimation rotation. We do use the ring structure. 2-centimeter ring help us to limit the 50% of prescription. Typically, we don't like 50% that's spilled out of the 2-centimeter ring. We do 5-millimeter ring outside the PTV, the maximum limited by prescription. And we do use a normal tissue objective, the distance from the target border set to 3-millimeter, where it starts at 100%, 4 to 40% within or for 0.1. It really depends. Sometimes 0.1 can be tough. Sometimes we see cases like 0.5. MU objective, we do use MU objective. Generally, it's about twice the fraction dose you are going to use. Like for prostate cases, typically 725 centigrade. You double it, it's roughly 1450 or 1500 MU maximum limit. So for dosimetry wise, those are SBRT cases pretty much specify the low dose 60-80%, right? And they are small and no margins for beam penumbra and the target edge. The rationale is the high dose for outside target volume, which will result in increased dose heterogeneity within the target. And the hotspot within PTV are often viewed to be desirable. We don't really like hotspot to be outside the PTV. Generally, we will kind of force it into the PTV. And the choice of a beam geometry, it's a dominant factor to achieve sharp dose fall off. Yeah, for prostate, pretty generally prostate only, pretty easy to the beam geometry pretty easy to achieve. To evaluate the plan quality, we start with as a physicist when we do the plan check, we call pre-check or new start. We typically look at the image fusion first, right? Like Dr. Guy mentioned, depends on where you are treating. The fusion can be off. So a lot of time we try to fuse based on the tumor target itself. So our image specialist doesn't provide the second fusion options. Sometimes they, as a default, they fuse by bony anatomy, but also they fuse by target. We check fusion most of the time check fusion for prostate between MR and the CT. We check the contours, including the contour physician draw, their expansion, does it make sense? Also the target, all the OARs, do we have all the contours? And also their contour accuracy, we also check them. We look at when we evaluate the plan, we look at the BMI view, look at the MLC. So in our planning, we use the jaw tracking, so that will help to reduce leakage from MLC. Yeah, you can see from this video here. Let me see if I can still play. Now I can play. Yeah. Yeah, we check the BMI view, look at the MLC. We look at the arc length, look at the modulations. For dosimetry evaluation, we do look at the target conformality, high dose spillage, and the intermediate dose spillage. Here, just on the tables, just a copy from GU005, the constraint for rectum, bladder, bowel, urethral, penile bulb, femurs, and others. So conformality index, yeah, we typically this one you should be able to achieve 1.4 very easily. For prostate, most likely you are able to. Oh, sorry. Okay. I would yeah, so most of the time, conformality index, we are able to achieve 1.1 or even below. It's not very difficult. And the high dose spillage, also taking into account the normal tissue, you try to force those high dose within the PTV away from the OARs. Intermediate dose fall off, we look at the 50%. So like one of the Merck gradient index, you look at the 50% prescription isotopes like versus the 100% isosceles. So ideally, they should be within for LINAC. It shouldn't be very difficult. R50, you 50% isosceles versus PTV volume. It's kind of difficult for small target. Either for larger target to get a decent ratio. But if you have trouble with the small target, large target, gradient error actually it's a better for those kind of scenario. Basically, look at the 50% isosceles distance from the 50% to prescription. So here at the WashU, we do a lot of scripting in area. Even for in Radiation, we also do the scripting. In area for prostate, say SBRT, we run the SBRT plan in the indices. Just look at the couple parameter, such as we look at the target volume. This is the screen grab on the left side. We look at the volume. We look at the conformality index. It's pretty good. It's a 1. Look at the R50 gradient index, gradient error. MU ratio, right? MU ratio, total MU arc length. Yeah, arc length, like I mentioned before, if you do 2 arcs with a 30-degree rectum sparing, you pretty much only left, you have a 660. On the right side, that's the table from BR001. So kind of help you to gauge where you are based on the PTV volume. For example, for this case, the volume is 114-ish. It's kind of close to 126. So based on the BR001, you R50, you are looking for less than 4. So we got 3.1-ish. That's a kind of decent number. So yeah, so we use this pretty often, kind of look at our plan. It's a good reference to have it. For the delivery itself, so generally we take a co-beam CT first. Then align with the fiducials and look at the blood and rectum fillings. Also look at the small bowel. Sometimes we don't specifically contour small bowel. It could be a bowel bag. Also the penis is not in the irradiated field. Then after the co-beam CT, we apply the shift. Then we use the daily KV to verify the seats locations. Fiducial markers. Some of our site, we have exact track. You can do intrafraction imaging. For downtown, we use the trigger imaging from TrueBeam. Typically, we kind of do every. It depends. Depends on what you define. It could be triggered by the gantry rotation angles, or triggered by MU being delivered, or triggered by the time. So those patients typically we treat every other day. I forgot to mention one thing. Typically, our SBRT prostate we treat on TrueBeam Edge, which have a high definition MLC. In the middle, about 2.5 millimeter. On the ESOs, they have this double stack MLC, which also achieve pretty good resolution. Image guidance. So yeah. So there are so many ways you can do, depends on what you have in your imaging localization. So it could be like on the left side, if you have MR LINAC, this can provide you real-time gating. It's pretty good. Or you can do exact track like in the middle, or like ESOs, typically for our SBRT adaptive case for prostate, or even any other pancreatic or lung, we actually do, before we deliver the radiation, we do a co-beam CT. And between, if we have like a say 2 or 3 arcs, we kind of in the middle, between arcs, not every single arc, we try to take one in between arcs, another co-beam CT to verify. So far, ESOs, they don't support the fluoro and the KV in clinical mode. So we typically get a 3D volume image. So you can also use the trigger imaging like a TrueBeam or other machine, or some of the clinic like our proton center, we have in-room CT, so you can take CT image as well. It really depends what you have. There are so many options you can do. For the reference, APM task group 179 provide a very nice summarize some of the technology, which then including some of the most recent, such as the ESOS or MR linear, but they have pretty comprehensive which kind of technique you have, what's corresponding limitation or pro and cons you can refer to. Just to show you a trigger imaging on the tubing on the top right, you can see that's the trigger imaging we took during the delivery. Those green contour, they are the markers. Typically, we expand the marker of fiducials by 2 millimeter. You see they are very nicely within the contours. The way how you add your trigger imaging, basically, you pretty much just go to your fields and you add your image and you ask for KV and it's during. You also apply to all the beams. In that way, you just add one time, you get all of them for the fields. So you can trigger your imaging based on the, as you can see, it's pretty small, based on the time, based on the MU, or based on gantry rotations. So so for us, we use we kind of at the very beginning, I believe we kind of use a 15-degree. Now we have full confidence. We kind of increase the angle. Now we do 30-degree rotation. Every 30, we take a interfraction imaging. So you don't really need to necessarily see all the anatomy because the KV have pretty broad field of view. So you may want to narrow down your KV blades, only look at the target region. In that, then you can reduce the imaging dose to the rest of the anatomy. And also remember to turn on your fiducials, right? If you don't turn on your fiducial target in your interfraction imaging, you may not able to see the whether you may not able to check whether the coil or markers within or without the contours. So for patient-specific PQA, for SBRT, it's pretty standard for all the SBRT cases, but specifically for prostate, typically we do a single point measurement using ion chamber in a kind of phantom water equivalent box. We also do portal dosimetry. We look at 2% 2 millimeter passing rate and 3% 3 millimeter gamma. Also, we have in-house software. We look at the Dynalog. So basically, after delivery, you have the logs. You can compare whatever been delivered and also been planned. This have worked. Nice summary of the gantry information, jaw, collimator, couch, MLC, and MU, and others. Just briefly touching the ESOS adaptive, Dr. Guy already mentioned is the last case. So we do have a variant trial to treat the prostate cases with the metastasis on ESOS using our online adaptive workflow. But before we start talking about the online adaptive, I just want to briefly tell you about the imaging system. The ESOS now has it. So yeah, back to a couple years ago, 2020, we started first adaptive in North America using this platform. It wasn't the HyperSite. It was a kind of iterative co-beam CT. The acquisition time is kind of in between the current HyperSite and the standard TrueBeam. You can down to 16 seconds. Depends how much. Sorry, it depends on which protocol you choose. I believe the SRS fast was 15, 16 seconds. But now the time is much faster. The HyperSite, you are able to acquire image within 5.9 seconds, and also you don't have to do the full rotation. So you only need about a 211-degree rotation. The reason is the HyperSite panel, it's much bigger compared to traditional TrueBeam panel. It's a 43 centimeter width in the longitudinal direction and 86 centimeter on the lateral direction. So pretty much every single image you acquire on the HyperSite ESOS, you pretty much get a full fan. You don't need to do like a half fan kind of scan. So 211 degrees should be enough. Here, I just show you an example on a lung patient. So you really can do just single breast hold. For 5.9 seconds, you get a very nice image versus standard co-beam CT. Yeah, you need roughly about a minute. In that sense, this is kind of just show you the diaphragm motion information based on the projection data. On the left side, you see the breast hold, the breathing is pretty flat, right? Just single breathing. But on the traditional co-beam CT, you have so many breathing cycles there, which of course can blur your imaging. Okay, on the right side, this is the kind of comparison between a plan made on simulation CT, simulated scanner versus hypersite. So pretty much their HU, based on the light profile, you can see the HU, they match pretty well with each other, even in the lung tissue, bone tissue, or any soft tissue, and also the dose distribution pretty close to each other. So for the adaptive SBRT prostate, typically we have 4 targets. We have the pelvis lymph nodes 25 gray, and the prostate with the semivascular to 36-25 gray, and the prostate plus gross disease to 40 gray, and the MR detected prostate lesion, those little lesions you see from Dr. Guy's slides are 50 gray. So those are like every, so it's a 5 fraction treatment once a week. Also, they have 4 separate defined target, and they treat simultaneously in the same time. So usually for those patients, we have an original plan. When patient come in, we take a CT scan, co-beam CT hypersite scan, and then physician and the physicist contour the OAR, physician contour the target. Then we just evaluate the plan, see if we need to do the adaptation. If we need it, then we just let the system do the sorry, I take it back. Usually when you finish your contouring, the next step is to automatically generate a plan evaluation, which is a scheduled compared to the scheduled plan, and also a adaptive plan. And you can see if the dose calculate on today's image versus original plan, if it's not too much change, your constraints are happy, you probably can go ahead using the scheduled plan. If there's a coverage improvement on the target or OAR, those kind of constraint breaks, and the new plan able to fix them, you're probably going to go ahead with the scheduled, adaptive plan. Yeah, here's just an example. I think Dr. Guy also mentioned the same thing. Like this little guy here, this guy, the mass metastasis, they probably gonna hit harder to 50 gray. Where nicely ESOs have this on the right side, you see this comparison between scheduled and adaptive. So basically, it's very convenient for you when you do the adaptation on the machine. After the contour re-optimize, and you can see the plan comparison between scheduled and adaptive. As you can see here, yeah, on the left side, the scheduled, a lot of things break, right? The red means break, green means happy, and the orange means kind of warning. It really depends the situation. Like a priority, P1 is the priority 1, P2 is the priority 2. Some of them just, they only have report. Probably it's not something you care, it's make your clinical judge whether you're gonna adapt or not. Most likely, you're gonna focus on your priority 1. Like for this case, for sure, we're gonna go adaptive because rectum constraints it's broken. Yeah, here's on the left side, just kind of show you the dose distribution of 500 centigrade, that's per fraction. You pretty much covered all the lymph nodes and prostate, the semivasculars, and then you have a different dose escalation of 36, 25, 400, 4,000, and 5,000 if needed. That's pretty much my talk. Yeah, acknowledge my colleagues offered some of the slides. I think that's it.
Thank you very much, Dr. Hao. And so there's a question, maybe for Dr. Guy or Dr. Abadana. For some centers that don't have fiducials, do you think that they still can treat SBRT for prostate?
let me stop sharing.
What was the question again?
The question for some centers, they don't have like fiducials, right? Can they still treat SBRT for
You know,
prostate?
I don't have it. I know there's people who do that in the community. All my experience, I insert the fiducials myself. We just had a faculty join from Northwestern University. They said in his campus, SBRT, they still do fiducials, but then for non-SBRT, they do like cone beam CT. But I just don't have a good experience. I know that I've been doing fiducials for SBRT. I've been doing spacing, and so far the patients are tolerating the treatment very well. Just don't know if we'll ever transition away from that. We all know that even when contouring with a traditional CT, the prostate, it's less accurate. So, now that you're going to be looking at a cone beam CT, is it going to be accurate when you set it up with your therapist? I think you're going to lose some of that accuracy. You might end up having to use larger margins in some cases. So I think there's a trade-off that it could be potentially lower quality, but I mean, you might look at the literature and see if there's any good series with good results.
Yeah, Dr. Abdana, I think our central for many of our SBRT for prostate, we don't use the fiducials, right? But we did actually use spacer. Is that right?
Can you hear me?
Yes, I can hear right now. Yes.
Yeah, we use spacer. We use MRI guidance, and we use SGRT for tracking.
Okay, but at Baylor St. Luke's, we don't have.
We don't
MR
use
guidance.
fiducial.
Right. I think it's still probably, it's just confidence level, I believe. Okay.
Yeah.
There's another question for physics. Yao, can you explain the reason for using the 2 collimator angles in the planning?
Oh, that's because the MLC it's about MLC modeling the leakaging from the MLC inter-leaf leak by rotating the collimation. You kind of average out this kind of problem.
Yeah, so if you keep the collimator at 0, think about when you rotate like it's VMAT, when you rotate the gantry angle to 360, right? If your collimator angle is parallel with the gantry rotation axis, your leakage will be one location. But if using the collimator angle when you're rotating like 360, right? Your leakage is average out. Yeah, that's the reason why.
Yeah.
Any
Also,
other question?
Sorry.
We are
Yes,
right on time.
Okay, cool. That's great.
Right on time. I know some of you come late. I guess it's because different time zones, and I know it's very confusing. And many of you are from different countries. Here is 8 a.m. We start at 8 a.m. in the central U.S. time. And so next time, we'll send you a reminder about 30 minutes before. So by the way, our next training session is scheduled on this Thursday at U.S. time. So, and the same time, different days, but we're going to focus on the spine and lung SBRT. And again, this video is recorded. We're going to share with you. Thank you very much. If you have any question, please send an email to Geneva. She's our training coordinator. Thank you so much for joining this training session. And thank you, our great speakers, Dr. Hiram Guy, Dr. Yao Hao, for your great presentations. Really appreciate your support for developing countries. I know this is a very, very important topic, and we definitely will continue to learn. Thank you so much.
Thank you.
Thank you. Bye.
Bye.